Insurance companies will not cover labs to be drawn if you don't have a diagnosis. So it's very common for your doctor to never check your hemoglobin A1C or your fasting insulin or any of these really important markers because they're discouraged from doing so. They need a diagnosis, a reason for that reimbursement, or they get in trouble. They get letters from the insurance company. So there are well-meaning gynecologists out there who finally are understanding or, have had their eyes opened like I did, but they're still trying to work within the broken system. And you can't. You're still not going to, get any help. So it's really important to listen to podcasts like this and hear the truth because our system is broken.
Today is the first of two parts of my discussion with Dr. Tabatha Barber. She's an OB-Gyn, and she is affectionately referred to and has a wonderful podcast called the Gutsy Gynecologist. So welcome, Tabatha.
Thank you so much for having me, Cynthia. We need to talk about all of this stuff.
I agree. So what during your training or when you decided to go to medical school, what got you so passionate about helping support women throughout their lifetime? Because I think about you as a GYN that is really thinking from, when we start menstruating all the way through menopause, you're not focused on one particular age group. You really do think about women on a continuum.
Yeah. Oh my gosh. So I was going to be a rock star when I grew up. I thought I was going to marry Tommy Lee from Motley Crue. And I had the craziest idea of how life was going to play out. I had no interest in school or any of that, but I got pregnant in 11th grade and that shifted my entire life. And I realized now that was, God's plan for me. But what I had a traumatic experience. I was on Medicaid and food stamps, and I was treated like a second-class citizen. I had a doctor assigned to me who was nearing retirement. It was some family practice doctor who did not want to take Medicaid, but it was required. So I was one of those patients, and nothing was explained to me. Things were done to me that I, many years later said, oh my God, what the heck? And that experience changed me. It opened my eyes to the fact that women don't have a voice and a choice in their health, and that we need advocates. We need people in those roles as physicians and nurses and administrators to actually think about those women and stick up for them and do what's right for them. So that really shifted me, and I ended up going back to get my GED. I went to a community college. I figured out how to get good grades. It's amazing what you do when you try. And I went to medical school. That was my sole purpose, was I was going to be a women's health physician. I didn't know even what that looked like. I came from a small town. We didn't even have gynecologists. So it all evolved, but I knew my purpose the whole way through. And here I am out in practice. I do all this hard work for 10, 15 years or whatever. And I finally become a physician, and it's such an amazing feat. But then I'm stuck in this broken system, and I'm cranking patients out, like it's a factory every 15 to 20 minutes, and no one's really getting better. My saving grace was delivering babies was an amazing experience, and women were so grateful. And I got so much praise for that. And I love seeing the babies out and about around town. But when it came to my women, my gynecology patients, I wasn't getting any success. I wasn't helping them feel better. It was always, what pill can I find for them next? What surgery can I do next? And so it felt very disheartening. And, I reached my breaking point when I finally had burnout, and I thought, I know God put me on this plan for a reason. I'm supposed to be changing women's life, but here I am stuck in a broken system. There's something missing. And what was missing was health and wellness. I was focused on ill and disease and just looking at life the wrong way and not helping my patients. And so I had to make real big, scary, brave shifts in my life. And now I actually help women feel better, and they heal themselves, and it's transformational, and they get their life back, and all of these amazing things. And that's why I became a doctor, so I heard Sachin Patel the other day saying something like, the medical system doesn't see you until you're sick, until you have a diagnosis and you are needing them. And then you get stuck there and you never get well again. So I want to help women not get to that point, or if they are at that point, get out of it. Like, I'm not in the business of keeping you feeling crappy. And so what I've come to understand is, like, we have these women who are done having children and there's no help for them. They're age like 35 to 45 and up, and they're seeking answers and their doctors just don't have any. So let's talk about that today. Like, why don't doctors have those answers, right?
Well, I think it's so important. And I have to really credit your life's journey as what has pivoted you to, really become this tremendous women's advocate. I always talk about the path less traveled, and certainly you've had an incredible path. And I'm so, so grateful that not only that we are friends and we are clinicians, but that you are one of many that are speaking out on behalf of middle-aged women, because I am the first person to say very transparently that when I hit the wall of perimenopause, which I did, I was not anticipating the changes that I was going to be experiencing. And just by pure happenstance, on the day that I was seeing my annual GYN and we had a good working relationship, I just happened to have my menstrual cycle started that day. And I'd been telling her my period was very heavy. And her first response wasn't, let's look at some other things. It was, let's fix this problem. We'll put you on oral contraceptives. We'll give you an IUD. If you don't want that, an ablation, or, best case scenario, we just take your uterus out.
Yes.
And I was like, time out. This is not an option. And I think for so many women, like, my mom never talked to me about these changes. My grandmother didn't. My girlfriends haven't. I've actually been the one that has encouraged them to talk about it. I said, I think there's so much shame in the aging process, and we need to give ourselves compassion, and we need to find the right providers to work with, because we are out there. You don't have to ascribe to the philosophy or the methodology that, your best years are behind you and now you just have to accept things as they are. So when I was doing a little bit of research prior to our discussion, I was really looking into statistics on perimenopause, which there aren't a lot of them, which is unfortunate. But we do know, statistically that 1.3 million women per year go into menopause. So that's 12 months without a menstrual cycle. But preceding that is perimenopause, this 5 to 10 year process. And what's interesting to me is that a lot of us, it's almost like we fall off a cliff. We don't realize that our ovaries are starting to produce less progesterone, which impacts our sleep quality. And if we're prone to anxiety or depression, that we then, evolve into having this relative estrogen dominance where we get these crazy heavy periods. I used to pray I would not start my cycle in the hospital because there was not enough, there was not enough equipment, supplies, / et cetera. Even the nurses, I mean, they would know. I would look this panicked look. I was like, oh my goodness. So on a lot of levels, I think let's start the conversation. Let's talk about what's happening physiologically to our bodies as we are, getting beyond the years. We're at peak fertility. What are the things that are changing in our bodies? And, really focusing in on what are ways that we can test? Like, this is the question I get asked a lot, which I know we'll touch on, but how do I know? Like, how do I know this is happening? What are the things I need to be asking my GYN or my midwife or my NP or PA, whomever you see? What are the things I need to do to prepare for this time period?
Oh my gosh. Yeah, we have a lot to unpack. So your situation was pretty typical. You went to the doctor, you have the symptom of the heavy period or the estrogen dominance, and they want to fix it for you. That's how we are trained. And, here's a kicker, which a lot of women are shocked by. Gynecologists are actually surgeons.
Mm-hmm.
They are not hormone experts. I came out of residency barely understanding menopause. I was taught perimenopause was this 3 to 5 year scenario of hot flashes, night sweats, mood swings. You put them on estrogen and they're good to go. That is literally what I learned. And that was 20 years ago. And then the Women's Health Initiative study came out and scared the bejesus out of everybody, and everybody got taken off their hormones and were told just deal with it. So now fast forward 20 years later, we're seeing perimenopause symptoms starting 10 or 15 years before you stop having that period altogether. And so we really need to look at that and go, why? The reasons are we are living crazy stressed out lives that we never have in any time in previous history as women. We are trying to do it all, be it all, have it all. You know, we're trying to look good and stay in shape and run businesses or have successful jobs and start our families and run our families. And we're starting our families later. And all of that chronic cortisol production to manage all of that really causes an imbalance in our sex hormones. So that is number one. Number two is that we don't love on our liver. We abuse our liver. We drink alcohol on a regular basis now, like we never have as women in the past, you know, especially the past couple of years, you know, we have been going to grab that glass of wine to handle those stressors or to handle that pandemic stress and anxiety. And when you're drinking alcohol every night and then you're taking Benadryl to help you sleep or Ambien and Ativan and all of these drugs, it's really stressful on the liver. And then there's the impact of our food. Our food is pretty much garbage in this society. I hate to say it, but I call it Frankenfood. It's not real food if you're eating out of boxes and bags. And so that's really hard on our liver as well. And then the other piece of it is that, you know, our gut microbiome. This is where I'm really passionate about. Gynecologists do not understand the association of gut health and gyn health. So your microbiome actually helps determine if you get rid of those used up estrogens and hormones, or if you recirculate them and reabsorb them. So your scenario of, my periods are getting a little heavier, that was a sign from your body that you were getting too much estrogen. And so that can happen from chronic cortisol production, depleting your progesterone. It can happen from your liver not metabolizing your estrogens properly. It can happen because you're constipated and not pooping regularly, or you have the wrong bacteria living in your gut, causing you to reabsorb those estrogens. And none of that is evaluated by conventional gynecologists. It's very much a Band-Aid approach. Let's get rid of that heavy period. So what I finally found after, you know, practicing forever and seeing these patients just having this recurring scenario is that you get rid of that symptom. I did a lot of hysterectomies and a lot of ablations and a lot of IUDs. A few years later, they would get diagnosed with breast cancer. And I stopped and I said, why? You know, and the problem is we didn't fix the hormone imbalance. So the estrogen continued to dominate. The progesterone continued to be low and not be balancing and protecting that estrogen. And you continue to not metabolize your estrogens effectively in the liver. And so that is a scenario that I see all too commonly. And I want conventional gynecologists to acknowledge this problem because they're actually contributing to it by covering up your symptoms, because it makes it easier to ignore this hormone imbalance.
I couldn't agree more. One of my best friends from high school, who is 51, is still on oral contraceptives. And I actually had a conversation with her and I said, we don't even know if you're in menopause, because technically the average age of menopause here in the United States is 51. And, you know, she liked the convenience. I totally get it. There's no judgment, but we don't know where she is. And she said, what would I even do? Like, what are the tests I need to ask for? What are the things I need to do? And so we kind of dove down this rabbit hole of trying to look like, what's the research say? And it's kind of it's a total, pardon me, shit show. I mean, there's not enough research. I mean, when I wrote my book, I talked about these 5 phases of perimenopause, and it was like, that required a lot of effort to find this one study talking about the phases, like what happens in the beginning, what happens towards the end. And I agree with you that we are band-aiding so many of these symptoms instead of addressing the root cause. And to touch on the estrogen piece, you can be having bowel movements every day and still not be excreting your estrogen properly. And I say this from personal experience that, I've done a couple Dutch and people are pretty familiar with that test because they listen to the podcast. And, I did it before I went on hormone replacement therapy. I did it when I was about 4 months in. And what was interesting to me was that clearly I was on not the right types of hormone replacement therapy because all of a sudden I went from excreting my estrogen properly to not. And so a lot of it was determined by the products we were using, and I'm off of them now, and my estrogen metabolism is better. But because I was having a bowel movement every day, I assumed, oh, I'm getting rid of the excess estrogen. No, I wasn't. And so I think if anyone's listening and says, well, I don't get constipated, so I must be fine. No, that's not the case. So, what are some of the tests that you like to use in your work with women right now that you feel like are beneficial for the perimenopausal woman? And especially those like I get DMs, I'm sure you get them too. How do I know where I am if I have an IUD? How do I know where I am if I have an ablation? How do I know if I've had my uterus out, but I still have my ovaries? I don't even know how to ask, like really respond thoughtfully to those questions. And I'm sure you have some ideas, but I know that I get those questions almost every day.
Oh my gosh. Okay. I'm going to let my dog out. I'm so sorry. She's being annoying. Sorry. Okay. I absolutely love that your listeners are asking these questions because that is key. We finally need to start speaking up for ourselves. I would love to go back quickly and just talk about your friend, the birth control on the birth control pill. Oh my goodness. So the problem with the birth control pill, there's multiple problems, but we're on them for decades. And, I'm an advocate of the birth control pill. That's how I didn't have another baby and made it through medical school, right? Let me put that disclaimer in there. You should use it if you need it for birth control. It's a good option, but you should have informed consent when you go on that birth control pill. You should know and be told that it is shutting down your own hormone production, your HPO axis. So your brain and ovaries are not talking to each other. Your ovaries are no longer responding to things. They're kind of put in a sleep mode. That is why you don't get pregnant, because you don't ovulate. It also causes leaky gut, and it causes you to no longer absorb your vitamins and minerals effectively. So I see a lot of B vitamin depletion and protein depletion and all of these things. And B vitamins are actually needed to metabolize estrogens appropriately. So the other thing is it shifts your gut microbiome. So you have different bacteria living in your gut. And you mentioned you're pooping every day. So I'm so glad you pointed that out, because it's not just you getting rid of, your stool evacuating, but there's certain bacteria that will cause you to cut the garbage tag off of those hormones that you're trying to get out of your system, and that will cause you to reabsorb them. So it's not just the physical movement or not. There's things going on microscopically that we need to be aware of. And so you can evaluate all of that with functional stool testing. It's pretty amazing. But what I see is women will go on the birth control pill either as a teen because their period is heavy and crazy and painful, which we could talk about all that. That's a whole nother episode. That's not normal. That needs to be addressed, not with birth control pills. Or you go on it for birth control and then you stay on it for the convenience, or your doctor keeps putting you on it to, handle these heavy period symptoms, etc. Those are synthetic hormones. They do not send the same signal to your breast tissue and all of the other receptors throughout your body that natural bioidentical hormones do. And so what we now understand is, even though it gets rid of your symptom, in other areas, it's doing you more harm than good. And so I would encourage women to only use it for birth control for the shortest amount of time necessary. That's what we say for hormone replacement therapy. So the idea is all these synthetic hormones are completely safe for 20 or 30 years. And then as soon as you're done having periods, they're no longer safe. Like everybody's got to get off them, shortest duration. And really the problem was the 20 to 30 years preceding you going into menopause. That is how cancer and disease develop. They don't just develop overnight, so having a 53-year-old woman go on synthetic hormones, that didn't cause the cancer. It was what was happening for those decades leading up to it. And I promise you that will not be addressed or researched or acknowledged, because imagine the lawsuits, imagine the millions and millions of women put on birth control pills since the 60s. That would, like, our society would probably collapse, honestly. So it's not going to be addressed. It's up to us to acknowledge these facts and say, okay, is this safe for me? Do I want to continue on this? Am I willing to take that risk? Some people are starting to understand that, but it's important to focus on your gut health, focus on your liver health, get your vitamin and minerals supplemented, because I guarantee you're depleted, and that's creating a vicious cycle. So when you take a synthetic hormone like estrogen or a synthetic progestin, your body is metabolizing it into a form we don't like right off the bat. We see that all the time with oral estrogen replacement. So you can get bioidentical oral estradiol as a menopausal woman, but 30% of it gets converted to estrone in your gut before you even put it in your bloodstream and use it. So you're putting it into a form that is more likely to damage DNA in your cells and increase your risk of breast cancer before it even gets into your bloodstream. It's these little nuances that your provider needs to know, and a lot of them don't. And so women are, they're causing more harm than they are good, because gynecologists are surgeons and they're not trained hormone experts. They're not learning this stuff. So it's really important for you to seek out alternative practitioners. I mean, I'm guessing that was your situation, right,
Yeah.
Cynthia?
Absolutely. And it's interesting. I want to dovetail into I was reading some research about oral contraceptives, that they even change the type of partners you would select. So maybe if you were not on oral contraceptives, you might be attracted to a different person, but because you were on these synthetic hormones, you end up coupling with maybe someone that you would not have otherwise chosen to be with. And that's really profound and powerful. And how many of my friends at the stage of life that I'm in, where we're starting to see people get separated and get divorced, women who are now off of hormones, and maybe they're looking at their partner and saying, we're not as well matched as we thought we were. And it's because at the time, well, I'm sure it's many things, but one thing that could have contributed is that we are disrupting this normal physiologic, whether it's pheromone production, et cetera, but that influence on the gut microbiome even impacts our ability to select the right partners. And I thought that was very, very telling. And I agree with you that even as a provider, I had to go outside the traditional medical model to get the kind of care that I wanted. And I'm so glad that you brought up the concept of informed consent, because how many of us don't even think about it? Whatever prescription we get, they might mention a couple side effects, but you're not really thinking truly, what am I consenting to for my body? One of the things I'm starting to see is women that were on long-term oral contraceptives, either to help with wonky periods or with contraception, later going on to developing osteoporosis a whole lot earlier, because they've been in this low estradiol state when they were at peak bone and muscle mass building in their 20s and 30s. That's something, again, there probably more research needs to be done, but my N of 20 or 30 is that pretty consistently when I'm saying, were you on oral contraceptives for a period of time, when you were younger, almost all of us were. And I find that really, really interesting. I'm not referring to osteopenia, because that's technically not even a diagnosis. If you've been told you have osteopenia, you should not be, comparing your bone density at 50 to your bone density at 20. That's not a reasonable comparison. So when you're looking or talking to women that have an IUD, or they've had an ablation, or they've had a hysterectomy and still have their ovaries, how do you help them understand where they are? If they're in perimenopause, like how do they know when they're done? Like, do you advocate looking at an FSH? Do you recommend they seed cycle? What are the things that you kind of recommend or suggest? Because this is something that this is actually my own question. Because when women come to me, I'm like, I don't really have a great answer. So I'm hopeful that you will have a better one.
Yeah, I think it's really important, especially for the women you mentioned that are essentially blocking those symptoms. Symptoms are messages from your body. Your body's trying to tell you something. So now you have to find another way to understand what your body is saying. And so if you're not having a period because of intervention, because you have a hormonal IUD or you've had an ablation, then, or you've had a hysterectomy and you still have your ovaries, we have to try and find out, are you still cycling? Because you don't have to bleed to be cycling. Cycling is the communication between your brain and your ovaries, producing hormones in different amounts every day of the month to cause ovulation, to cause release of that egg for a potential pregnancy. And that will still happen if you don't have your uterus, but you still have your ovaries. And so I always encourage women to get in tune with their bodies and try to understand what they're doing at different times of the month. And it can take a few months, really, because we're trained from a young age to just ignore it, just figure out how to deal with it and move on. My daughter just started her period. I'm sure she's super happy with me announcing this, but she was mortified and she was like, I'm not telling any of my friends. Like, that is how it is in America. We don't talk about it. We just cover it up. We're ashamed. We're embarrassed. We're scared. And so that whole conversation has to change. But in the meantime, we have to do all the crap that was done to our, way of thinking as women. So start getting in tune. When do I have energy? What days of the month? Like, write it on the calendar. When do I feel like, oh my gosh, I could go out and conquer the world? That's usually about 7 to 10 days long. When do I want to rest and take a nap and sleep in? When do I just need a massage? When does my body hurt? When is my brain fog kicking in? When do I want to have sex? When I'm all of a sudden I'm interested in my husband for like 4 to 6 days of the month. Where's that at? And really try to map that out, and you will figure out where you are in your cycle. So the other piece of it is you can do ovulation predictor kits to see when are you ovulating. And that's another piece of the puzzle. Or to take your temperature. You have to take it like before you even step out of your bed in the morning, like right away, because your temperature will go up half to 1 degree when you ovulate. And so all of these little pieces of information, you can kind of put them together and figure out where you are. So I know for me, like, I'll be tired and want to cry myself to sleep like the day before I start bleeding, and then the first day of my period, and then the second and third day, I'm like, let's kick ass and conquer the world. And I'm feeling amazing. I want to intermittent fast. I don't need food. I'm good to go. A few days later, I want to have sex again, and my libido's up, my testosterone's coming on, and things are good. Then I ovulate, my cervical mucus gets thicker, there's more moisture, all of that. And then, about cycle day 27 or 26, I'm like, man, I don't want to do anything. Why am I trying to conquer the world? Like, I'm overwhelmed. I'm crying to my husband. And then it starts all over again. And it took me a long time to figure that out about myself. That's not something I learned as an OB-GYN resident, unfortunately. And when I realized it, I started paying attention to my patients, and lo and behold, that is a common thing for all women. That is how we feel throughout the month based on our hormones cycling, because estrogen is our growth hormone. It makes us want to do stuff. And so estrogen comes in early in the month and we get going, we get hustling. When we ovulate, our body's like, she might get pregnant. We better hunker down, conserve energy, focus on that uterus in case that egg implants, and so things turn down and it's focused on restore and restoration. And in the middle, when you're trying to ovulate and get pregnant, that's when the testosterone is high. And so I remember learning the little pictures of these levels going up and down in residency, but no one ever sat down and explained how women feel during this time and how to help them be vibrant and make the most out of it, like how they should be exercising and, eating. And you've done an amazing job with that. And so has Better Body, Dr. Estima, like so many women are finally talking about this. And I would encourage women to embrace this and teach this to your daughters. Like, a new time is coming. We're no longer just going to be trying to get rid of our period. Like that was super popular in the early 2000s. Seasonique came out. Let's not have a period for 3 months. Nobody needs a period. We don't want periods. They're bad news, and it just further caused more shame and more frustration. And that pill was horrible. Like people were having breakthrough bleeding like you wouldn't believe. It caused a lot of emotional frustration, a lot of depression, anxiety, because when you mess with sex hormones, you're not just messing with your period, you're messing with how you feel as a person, how you function, your energy level, your immune system. It's all balanced by your hormones.
And I think that's such an important shift in your perspective. I know for myself, I say now, now that I'm done having menstrual cycles, I now know more about the menstrual cycle than I ever did before. And I was like, how sad is that? And it really speaks to the fact that menstruation was kind of thought of as dirty and, you don't talk about it and you're always making excuses for it. And, like you mentioned, creating contraception that, de-obligates us from actually having something that should otherwise be pretty natural. And I'm always very transparent and tell people, I thought I had horrible PMS in my 20s. I didn't have terrible PMS. I had bad PMS, I put it in quotes because I wasn't really having a menstrual cycle in between packs of pills, but I had awful PMS symptoms. And I didn't know that that wasn't normal for me until I went off the pill when my husband and I got married. And all of a sudden I was like, I actually don't have PMS. But it's because of these synthetic hormones, disconnecting parts of my brain to my organs that's not, functioning and optimally working. Do you suspect that one of the reasons why we don't talk about energy and sex drive and, cravings with our patients is that it's harder to measure? Do you think that has something to do with it? Because when I think about like, why hasn't the research really been done in this area, at least that I'm aware of? Is it because it's considered to be a tougher, variable to plan for? Like, I know I actually did a presentation last week in Salt Lake and I was talking about, I forget, it was from like 1973 to 1993, women were not allowed to be in any phase 1 clinical trials. And that has started to shift. And yes, that was over 30 years ago, but it shows you that there's not enough research being done on women because there's concerns that our menstrual cycle is too complicated. It's a variable they don't want to account for. And my hope is, that our generation of women is going to ensure that, my nieces and your daughter and all these other young people, that they're going to age and mature very differently than we did, with more information and more awareness and greater empowerment.
Yeah, without a doubt. I mean, you hit on some important points, and I want women to understand that the majority of studies that are done on women are done by drug companies in an effort to get rid of those symptoms for you. It's like, does this drug work for this symptom? That is what they're studying. They are not studying how can we get your body to be in homeostasis and function on its own. Those studies aren't being done because no one makes money off of you being healthy and not requiring medications and surgeries. Everything is very much focused on, did this surgery work for endometriosis? Did this pill work for, your bleeding? So I want women to understand, like, your doctor focuses on evidence-based medicine and makes all their decisions on evidence-based medicine. And the evidence is not there for women because the system is broken. So it very much frustrates me when my colleagues say what you're doing is not evidence-based. That is because it's never going to be studied until we shift how we view healthcare. I put those in quotes in our system. So you mentioned like it is hard to measure libido and things like that. But the bigger issue that I find is that you don't have time to talk to your doctor about that. I got penalized for taking time with my patients. I had to sit in meetings every month with like 3 or 4 managers and be told that I'm not seeing enough patients. I'm not doing enough surgery. I'm not making enough money. I'm not doing enough deliveries. I promise you that all of your doctors, that is how it works, unless they're in private practice, which is almost impossible in this day and age. So they're all hospital owned, salaried physicians being told how to treat you. And they are being told you get 15, 20 minutes, you get 20 minutes if it's an entire annual exam. So you got to crank out the physical and find out how they feel and fix the problem in that 20 minutes. There's no time to talk about, are you moving your body? Are you going through a divorce? Are you having a midlife crisis? Are you eating garbage? Are you sleeping? None of that. And so we never really get to the root cause of the problem, not even to mention deeper issues like mold and Lyme and all those chronic things that don't get addressed, but like basic lifestyle stuff. So I say, don't even be mad at your doctor. They're just as broke as you. They're probably just as unhealthy and just as sick. Physicians and nurses are the most overweight, unhealthy profession there is because they don't have time to take care of themselves. So they can honestly not be an example for you as a patient. I know I was broken. I was living on donuts and coffee and falling asleep at lunch, and yet people were coming to me with their health issues and I was giving bad advice. And so it's so broken. I don't even know where to start. That's why I'm just starting with the women, like seek alternative solutions. So what I say is ask why. Why do you want to give me this medication? How long do I need to take this for? If they don't have clear answers for you that sit well in your gut, don't take it. I don't know about you, but using antidepressants for perimenopause, that's the new craze. That is recommended by the American College of OB-GYNs, by the North American Menopause Society, which, I'm all board certified through these places. That is the standard of care. If I have a woman complaining of hot flashes and night sweats, I'm supposed to start her on Lexapro first line. That is what I'm supposed to do. And you know what that causes? More weight gain, more self-esteem issues, not wanting to be intimate with their husband. So then they, spiral and feel 10 times worse. And then they can't get off the medication because it's impossible. It's so addictive. You have disequilibrium, or you feel like you've had, alcohol to drink. You get all of these side effects. So just examples like that just infuriate me. And I just want to say, like, enough is enough. Stop with this pill for an ill. It's really harming women.
Well, and I think it's so important because you're being so transparent about your lack of ability to provide the kind of care that your patients deserve. I felt very similarly. I think most people know I worked in cardiology, and I used to call it the question that I would get asked as I was walking out the door. Now, the nurse practitioner service in my practice, if I was in hospital, I was managing all the patients. If I was in clinic, I was seeing hospital follow-ups, and usually the sickest of the sick people, because the docs didn't want to see them. They were like, go talk to the NP. And I loved my patients, but the handle on the door question always centered around sex. They wanted to ask me the questions because they weren't comfortable enough asking the cardiologist, which was generally a male. And I used to say to my husband, kind of humorously, I would say the people that had enough courage to ask about their sex lives were never the people I would have assumed were having sex. So it just goes to show you, they were the ones that were courageous enough to have that discussion. And so I would always sit back down and have that discussion, because I kept thinking, if they're asking me in the cardiology office, it speaks volumes because someone else isn't asking that question or answering that question for them. So I think that's absolutely critical. What's interesting, and I know we're going to talk about this in our episode that's upcoming, when we're talking about vasomotor symptoms. So those symptoms that women get where they feel like maybe they're burning from the inside out, they're having hot flashes. If you really look at the research, it's not a depression issue. It's generally a blood sugar dysregulation issue. And it's
Mhm.
interesting, the leaner your body mass is, the less likely you are to experience these vasomotor symptoms. And it's actually protective against insulin resistance. But are we talking to our patients about that? No, we're prescribing medications because that is what we have been taught as clinicians, that a pill is going to fix that symptom. And
Right.
obviously, goodness, I mean, I can't tell you how
Well,
many
I was
women.
just going to say,
Yeah.
to add to that problem, insurance companies will not cover labs to be drawn if you don't have a diagnosis. So it's very common for your doctor to never check your hemoglobin A1C or your fasting insulin or any of these really important markers, because they're discouraged from doing so. They need a diagnosis, a reason for that reimbursement, or they get in trouble. They get letters from the insurance company. So there are well-meaning gynecologists out there who finally are understanding, or, have had their eyes opened like I did, but they're still trying to work within the broken system. And you can't, like, you really just can't. So don't even be mad at them. Don't even try to fight it and get angry, because if they say no, they can't do it, it's either because they're afraid of getting in trouble from their administrator or the insurance company, or they don't know how to interpret the results. That's my other key point I want women to understand is, as a physician, I was trained how to evaluate and treat disease. I was trained to look for disease. So when I ordered a hemoglobin A1C, if it was less than 7, I was happy as a clam. I was like, you're good to go. We'll see you next year. When in reality, you are sick. 5.7 is pre-diabetes, yet we say, yeah, you better work on your diet. We'll see you next year. Do we talk about the diet? No. Do we change anything? Do we send them to a nutritionist? Maybe if you're lucky and you have really good insurance and you're going to go see a dietitian who recommends the American Diabetes Association diet, which is garbage. I'm just going to be honest right now. You're still not going to, get any help. So it's really important to listen to podcasts like this and hear the truth, because our system is broken.
Absolutely. Well, Dr. Tabatha, this is the end of our part 1. Let my listeners know how to connect with you, how to listen to your amazing podcast, how to find you on social media.
Oh my goodness. Yes. Go listen to the Gutsy Gynecologist show. I talk about all kinds of, things covering women's health. It's not just gynecology, because we are more than our lady parts, right? But follow me on drtabatha.com. It's Tabatha, no I's. I'm on Instagram and TikTok at the Gutsy Gynecologist. So I hope you guys check it out.
Absolutely. Thanks you again for coming on. Okay, we're going to go with episode number 2. Let's talk about menopause. I think this is a hot topic nowadays. I think largely because more and more women are becoming more comfortable. But what are the more common confusions or terms that you feel like women are particularly uninformed about in terms of menopause?
Okay. Oh gosh, are you asking me? We're already there. Sorry, I thought we were prepping for the show.
No, we can. Do you want me to start it over?
Yeah, go
Okay,
ahead.
we're going to start over. This is the second episode with Dr. Tabatha. Tabatha, it's so good to connect with you again. I would love to do a little bit of a deep dive into menopause. Like, I kind of refer to it affectionately as puberty in reverse. But let's dispel some of the myths. What are some of the confusions or terminology that you feel like your patients really struggle with around this time in their lives?
Oh my goodness. So this is what I used to hear in the office all of the time. I'm done having babies. I don't need to see you anymore, right? Huge myth. That is not true at all. You still need to have your ovaries and uterus examined periodically. You need a breast exam. And if you have a good gynecologist, you're going to talk about your hormone journey and how things shift and change. And if you don't feel like your gynecologist is capable of that, then find someone who is well versed in hormone replacement therapy, or at least understands the menopausal transition. I always tell women, You don't need to be on bioidentical hormone replacement. You don't need to go into menopause naturally. You need to do what feels right for you. And you need to know all of the options and the risks and benefits and alternatives. Like that is how I'm just so strong about that. Like you should know what you're signing up for or not, because I came out, of training at a time where hormones were dangerous and scary. And we just have this idea that women's hormones are not safe, and it's complete garbage. It's totally false. Our hormones are very protective, and we need to understand that when we go into menopause and our hormone levels go down permanently, they're now at this, nice low level continuously, that we are no longer protected, and our risk of heart disease goes up, our risk of diabetes, our risk of dementia, our risk of bone loss, not to mention the vanity things, our skin changes, our eyesight, our hair, our nails, all of that stuff, our libido. So women need to know that hormones are not only safe, but they are healthy and they keep us from aging. And so it's up to you whether or not you want to do bioidentical hormone replacement therapy, but you're not being told the truth to make that decision in the first place. That's where I get fired up and angry.
I bet. I bet. And for listeners, I did an amazing podcast with Dr. Avram Bluming and Carol Tavris earlier this year talking about the book Estrogen Matters, which I strongly encourage everyone to read and make informed decisions. And I really agree with you that I would say it's like 50-50. 50% of the women that are roughly my age-ish or a little older, many of them are using some type of bioidentical therapy. And then there are others who are choosing not to, and there's no judgment. But I think it's important that you make an informed decision. Remember in our last episode, Dr. Tabatha was talking about informed consent, why it's so important that you make a decision from a place of knowledge, not out of fear. And yes, we both trained around the same time, because I remember in around 2002, when I was finishing up my medical training, saying to my mom, oh my gosh, the Women's Health Initiative comes out, and I was like, estrogen's bad. And now we realize it was just really bad data that they extrapolated and the media perpetuated. And now you have not just patients who are scared of hormone replacement therapy, but clinicians, which just perpetuates the bad information. And I think it's really impacting women on really profound levels. I always say that the older I get, the more I think about brain health. And there's a great book by Dr. Lisa Mosconi, The XX Brain. I hope eventually to interview her on the podcast. She's doing a lot of research right now. But that book really changed my whole perspective on hormone replacement therapy. The more I understood about the physiology of the brain and how all of our sex hormones, not just estrogen, but progesterone and testosterone, have signaling areas in the brain that impact our ability to not just metabolize glucose, but have clear, cohesive thoughts. And whether or not people recognize this or not, women are largely protected from things like cognitive issues and Alzheimer's until they go through menopause. And why does that happen? Because we lose estradiol signaling, and estrogen is an insulin sensitizing hormone. And we really need to think about Alzheimer's as a type 3 diabetes, or we need to understand it really at the basis of that is insulin resistance. And I think it was interesting. I think it was Bruce Willis recently, kind of sounds like maybe there's some cognitive deficits going on with him. And I actually said to my husband, I probably have no doubt he's gone through andropause. Yes, it happens to men too. It isn't just women. And the number one reason why men develop insulin resistance here in the United States is either from exposure to estrogen mimicking chemicals / insulin resistance. And it would not at all surprise me if that's contributing. I don't know anything about his medical care. I'm just surmising from the outside based on what I've read.
Yeah, it's so important. And that's been more important to me lately. Like you mentioned, once you start transitioning and you are no longer having regularly cycling hormones and you're getting that brain fog, all of a sudden you realize how important it is to have your brain health when you don't have it anymore. And I commonly see women age 60 to 65 coming to me. They're 5-10 years out of menopausal range, and they're like, I can't think, I can't concentrate, I can't remember anything, I can't sleep. And they want their hormones back, because no one had that discussion with them. And it's really frustrating that the most commonly heard thing is, Well, if you're not having hot flashes and night sweats, you don't need hormones. That's the other big myth that's being perpetuated by conventional medicine. The third one that kills me by gynecologists is, if you don't have a uterus, you don't need progesterone, right? Progesterone is only to protect the uterus from overgrowing its lining and causing uterine cancer. That's totally false. As you mentioned, there are receptors all over our body, in our brain. We metabolize progesterone, into a couple different forms. One is called alpha pregnenolone, and that actually hits our GABA receptors in our brain and prevents all that anxiety and insomnia that so many women are struggling with during perimenopause and menopause. Our body likes our hormones. The key is they need to be bioidentical. You mentioned the study, the WHI, that just shifted life for millions of women. So many problems with that study. First of all, they were studying synthetic hormones, conjugated equine estrogen from horse urine. That's not what we make. They were studying a synthetic progestin, totally not what we make. And they started women, average age of 64, I believe, on these hormones. So they were already over 10 years into menopause and having heart disease and diabetes and dementia and everything else set in. So many problems. Then there's two arms to the study: estrogen only or estrogen and progesterone. So the findings of the study weren't even explained correctly. It was really that the synthetic estrogen was increasing your risk of blood clot and stroke, and adding that synthetic progestin was what increased breast cancer, by like 1 out of every 1,000 women or something. So the findings were not of statistical significant value. They were not the hormones that we would recommend. They aren't given in the way that we recommend to give them. So we've learned so much since that study almost 20 years ago at this point. And what we've learned is that hormones are safe if you are mimicking your own physiology, if you're, monitoring it. And the bigger piece, like that I want to drive home, is that you're metabolizing them correctly. Mm-hmm. So I can give you bioidenticals, but if you're not doing the other work to have a healthy liver and a healthy gut and moving your body and all of these other things, keeping your blood sugar in control, then you can still have risks with those bioidentical hormones, because it's not just about your levels and your amounts, it's how you're metabolizing them. I can't emphasize that enough. So that's where testing is really important, and being monitored and knowing what is your body doing with these things that you're putting in them, right?
Well, and I think it's really important because, again, we've conditioned our patient population that a pill is going to fix everything. And oftentimes when I'm talking on social media, or I'm talking about my personal circumstances, that my own journey, I always say that if I didn't have all the other things dialed in, I could have a very different experience. Like, you have to get the sleep dialed in, you have to get the nutrition dialed in, you have to get the gut health dialed in, you have to do all these things before you band-aid with hormones. And the hormones, let me be clear, if you want to take hormones, by no means, I mean, it's the right decision for you. But if you're not doing all the other work, it's not going to help you. How many women do you see that say, oh, I got put on HRT and I feel better, but then I gained 15 or 20 pounds? I'm like, well, you have to back up the bus. Like, you can't eat like you did when you were 20. You can't get by with not getting enough sleep. You can't be, especially in light of the fact that, and I'm hoping we'll touch on some of these things, some of the physiologic changes that are occurring in our bodies as we make that transition into 12 months without a menstrual period. When you understand the physiology, it explains why sleep becomes more important. It explains why stress management is not just 2 minutes of meditation once a day and you check the box. It explains why anti-inflammatory nutrition is important, and why, you might not tolerate alcohol anymore. I'm always super open. And I say, I've never been a big drinker, but during the pandemic, I was the social drinker. And so I wasn't doing anything socially. And I actually said to my husband, every time I have a glass of wine or a martini, my sleep is terrible. Just one. My sleep is terrible. My REM scores are in the toilet. I have hot flashes, and it just isn't worth it. And so if I don't drink alcohol, I don't have those symptoms. And when I suggest that sometimes to people, like on social media, as the reason why I don't do it, they're like, oh, I never would have, made that connection, but I think it's important. Each one of us might need something different to have a big impact. Now, I'd love for us to like start from the beginning, starting from when we are born. We have so many primordial follicles. And so by the time we, go into puberty, we have like 300,000 follicles. And so by the time we get to close to menopause, we have a lot less of those follicles. So kind of talking about, each month, ideally, when we're in peak fertility, we're having an ovulatory cycle, releasing an egg, hopefully the healthiest egg of what's available. So when we go into menopause, do those eggs, do they become dormant? Are they dead? What happens to those eggs?
So that's a great question. And it's important for women to realize they are born with the eggs that they're going to have and potentially, use to have a pregnancy and create a human. Whereas men, they make their sperm every 48 to 72 hours throughout their life. And so it's completely different. It matters how healthy your mom was when she was pregnant with you, because that determines the health of your eggs and your baby. It's amazing to me. But that piece becomes really important in fertility issues because, I do case reviews for Fab Fertile. They help with fertility with high FSH, low AMH. So your FSH is follicle stimulating hormone coming from your brain, and it's telling your ovaries, make more estrogen, get ready to ovulate. And sometimes doctors will measure an FSH level and they will determine your future off of it. They will say, oh, you can no longer get pregnant. You need donor eggs, IVF. You're in menopause, you're done. And I will tell you, I see FSH get reversed all of the time in my Fab Fertile clients, that I do case reviews for, because it's a dynamic situation. Hormones are very dynamic. It is not a light switch. It's not you on and off. It's not one and done. And so say you're 35 years old. Yeah, you missed a couple cycles. They draw an FSH. It's 40. Oh, you're in menopause. You're done. We'll see you later. Well, then you have a period 6 or 8 months later and you're freaking out. Like, what's wrong with me? Do I have cancer? Am I okay? Because it's not a light switch. It's dynamic and things affect and talk to the brain all of the time. Like, not only are your ovaries talking to your brain, your thyroid is talking to your brain, your adrenal glands are talking to your brain, your pancreas is talking to your brain, like all of your blood sugar, your cortisol, your thyroid, they're all influencing your sex hormones. And so it's really important for women to understand that your body, first and foremost, wants to survive. So it's going to choose that route first before it starts to procreate. So if everything's dialed in, then your sex hormones can get attention and get balanced. But everything else is a mess, then that's going to be the last thing to be dealt with. Same thing with your liver. We talked a lot about it on the last episode that we did together. Like, your liver has to metabolize your sex hormones, but it's going to choose the alcohol toxin that you just ingested first over those sex hormones. So your estrogen will be dealt with later, if ever. Because if it keeps dealing with alcohol and Benadryl and Ativan and stuff like that, it's never going to get to your estrogens, and they're just going to pile up. I think of it as like, you have to not only take the garbage out of the kitchen and put it on the side of the road, but the garbage truck guy has to come and take it, or it will pile up on the side of the street. So there's a lot of different, places in your body that you need to be thinking about, how is this affecting my hormones? So back to our cycle. So we get in there, our brain, our ovaries start talking. That causes menarche, our first period. Things continue on. I just want to point out a couple things. Periods shouldn't be miserable. They shouldn't be heavy. They shouldn't be so painful and horrible that you miss school. You shouldn't have crazy migraines. Those are blood sugar issues, heavy toxic burden issues, too much cortisol. Those are other issues. That is not your sex hormones. So first and foremost, if that's all you got from this podcast, that's huge. So when you start cycling, you are producing estrogen from that FSH response. LH comes in and says, all right, everything looks good. Let's ovulate. Boom, you release an egg from the ovary. The place where the egg actually was is now called the corpus luteum on your ovary, and that's what produces progesterone. You know, it used to be common for PCOS to go in and do ovarian drilling. I don't know if you remember this, but
No.
surgeons, you know, gynecologists are surgeons. We were trained that we would go in laparoscopically and drill a bunch of holes with cautery, with electrical burning technique, and burn a bunch of holes in the ovaries, and that would fix your PCOS. That was super popular for a while, when really all it was destroying those follicles that you have left, so you have less ability to ovulate and less ability to make progesterone. And so it actually made PCOS 10 times worse, because then your androgens were really unbalanced and there was no progesterone to keep it in check. So unfortunately, we try out a lot of things on women. Women are kind of like guinea pigs. So just know that if you don't ovulate, your ovary can't make that progesterone that you need. You can get a little bit from your adrenal glands and other things from pregnenolone being changed, but that's really insignificant. So, you know, it used to be that you would ovulate consistently until about age 45, 48, and then you would be running out of eggs. And so you wouldn't ovulate and you wouldn't make progesterone. And then your brain would go, oh, okay, we're done doing this. Let's decrease the amount of estrogen. And then you would slide into menopause. But the past 20 or 30 years, women's lives have changed so significantly that that's no longer a smooth, short transition. It's now like a long process. And so we really need to dial in what's causing this prolonged perimenopause so that we can transition smoothly into menopause. And then we need to change the conversation of, how do you want that to look? Do you want it to be natural? Let's make the most of it. Or do you want to slow this aging process and kind of suspend yourself in the 48 age range with bioidentical hormones? And what does that look like in a healthy, safe way?
And I think it's really important. You know, when I was prepping for our conversation, there was a statistic I found really interesting. It was saying that if you're in, you know, mid to late perimenopause, 2 skip cycles in a row gives you a 90%, 95% chance that you're within, I thought this was ironic, 4 years of menopause. I was like, I would think as you start skipping cycles, you're getting closer and closer to that. And then on top of that, it was interesting. It was saying that 2 years from menopause, 50% of your cycles, they're completely anovulatory, meaning you're not ovulating, you're bleeding, but you don't even realize that you're not ovulating. And I think for many women that are in, you know, mid to late 40s, excuse me, most of them are not really focused on conceiving a child. They're not even thinking that way. But it's surprising to me how many women I speak to who are in this kind of late perimenopausal transition. They're like, oh, I can't get pregnant. I'm like, well, technically, you know, you probably could. It would probably be a surprise if it were to occur naturally, but just understanding that when your cycles really you start skipping more cycles, you're getting closer to that transition. And I think a lot of women don't understand. They just say, oh, well, I got, you know, a period once every 4 or 5 months. You know, that's fine with me. I just don't know when it's going to come. And much to our last conversation on our last episode, kind of leaning into how do you feel, what's your libido like, what's your energy like, to kind of get a sense of where you might be in this long protracted cycle.
Yeah, definitely. And, you know, it's important for women to realize that you can bleed, like you mentioned, without ovulating. So estrogen is coming in the first half of the month and it's stimulating that uterine lining, that endometrium, to grow. And so even if you don't ovulate and produce progesterone, the lining still grew and it's going to shed eventually. And without progesterone, it's probably going to shed earlier. So it's really common to see your cycle start to be every 2 to 3 weeks as opposed to 4 weeks. That's a really common complaint. And that's telling me you don't have progesterone there to keep that lining stable and hold on to it for the entire 4 weeks. It's being released early. Or skipping months is when your estrogen wasn't high enough to stimulate growth period. So nothing bled, nothing had to be released, but it's so common for women to have that symptom cover up. We don't have that as a gauge. And I love having that as a gauge. So I'm really not a proponent for an ablation or a hormonal IUD unless it's really significantly necessary. So these are important conversations to have individually. And I would love for women to go to their gynecologist and the gynecologist to say, let's figure out why you're having heavy periods. Let's not just cover it up. So I foresee that future. It's got to happen. It really does. But in the meantime, you as a patient have to be your own self-advocate and say to the doctor, why am I having heavy periods? And if they say it's because you're aging, that is a lie. That is not a true statement. Aging does not cause heavy periods. There's no physiological explanation for that. It's because of the dysfunction in the other areas that we talked about on the last episode. And so it's really important for women to realize. So your perimenopausal transition doesn't have to be 5, 10, 15 years of misery being on this roller coaster. You just have to dial in the other stuff. And then we can transition so much smoother. And I think intermittent fasting, that was a key for me. Like that was a game changer without a doubt.
Well, and it's interesting because my natural inclination was to kind of dive into what are some of the things that can impact how quickly a woman transitions into menopause from that transitional period. And I was thinking about meal frequency and insulin resistance and how we know that can exacerbate a lot of the symptoms women experience in perimenopause. But something I thought was interesting is, what has been your experience with women? I don't know a lot of people who smoke. During my training, I saw a lot of it because I was in inner city Baltimore. But it's interesting when I was looking at like tobacco use as being a risk factor for going into menopause earlier, what I found interesting, and I'm curious to know if this was your experience, that smoking in and of itself causes irreversible damage to the ovarian follicles. And then secondary to that, blood flow. So it would make sense that smokers would probably be at greater risk for going into menopause at an earlier age. Was that your experience with your patients?
Oh yeah, definitely, without a doubt, and causing infertility because our fallopian tubes have these tiny finger-like projections inside of the tubes, just like our intestines do. They're called pili. I'm blanking out for a second. They're called pili, and they move things along. And so if your fallopian tubes have stunned or dead, fingers, they're not going to move that egg through there, and you're not going to be able to get a fertilized egg. And so that can be really affected. Luckily, I don't see a lot of women smoking nowadays. We're finally getting the message that it really compounds, especially menopause, just compounds all our hormonal issues. I will tell you the biggest thing that I see for premature menopause is stress. Women who go from like dusk till dawn, 12, 14, 16-hour days, nonstop. They don't sleep. They're sleeping probably 4 or 5 hours max, consistently over time. They're over caffeinated. So they are driving this major adrenal cortisol dysfunction pattern, and they're living on all the stimulants required to keep them going, all the caffeine, the nicotine, the alcohol, all of these things to get them up and then put them down, get them up and put them down. And if you do that long enough, your sex hormones will say, yes, she does not love us. She does not want us to cycle. And that is what I see consistently. Women who stop having periods, 43, 45, 47 years old, that's their life. And so sometimes it's salvageable if you catch it early enough. That is the time that I rarely see it reversed. I talked about FSH levels going up and affecting your fertility and you're not having periods. If it's for other reasons, it's almost always turned aroundable. If it's from this chronic adrenal, dysfunction, you have to make major life shifts for that to reverse the effects that it's had on your sex hormones. So if you're listening to this and you're like, man, I can tell that my hormones are off, and that's me living that crazy life, like, you're going to have to make some hard choices. You're going to have to evaluate your boundaries with work, with life. You're going to have to really start writing in the calendar self-care stuff every single day and making some major shifts, or you will definitely go into menopause, and then you're going to have to deal with that.
Yeah. How about women who are underweight?
So that's another issue. We see low BMI or highly athletic women not produce enough estrogen. A little bit of estrogen is actually made in our fat cells. And so it's kind of this feedback thing where estrogen is a growth hormone. So it feeds our fat, and our fat makes more estrogen. You want to find that happy balance, that happy medium, because if your BMI is too low, then we don't see enough estrogen, and that increases your risk of bone loss and fractures, and it increases your risk of premature menopause. So I would say that's the woman that I want to focus on high quality proteins and healthy fats and weight training, and really focusing on muscle health and muscle strength, because muscle keeps your fat in check. Muscle, burns the fat, but that is going to keep her stable longer. I don't ever suggest like just try to gain weight and gain more fat. I don't think that's healthy. I don't know. I would love to hear your 2 cents on that.
Yeah, I mean, it's interesting because I've had quite a few women that are, and I'm not per se identifying them as anorexic, but they're very fixated on their weight. And so I get a lot of these women who want to fast because they want to maintain their weight, and they get very fixated on the scale and the weight. And I know from everything that I read is that the lower your fat mass, and we're talking about like very thin women, I'm not talking about like an average lean woman, we know it can accelerate follicle aging. And so that was one of the reasons that I was curious to ask, was that, has this been your experience as well, that I am seeing women 47, 48 going through earlier? I definitely think in 2019, when I lost 15 pounds, because I'm not a big person, that pushed me over the edge. Like I know I was getting closer, but I do think that contributed, because I lost so much muscle mass. I had no fat left on me when I left the hospital, and it took a period of time to gain healthy weight back. And I remember saying to my GYN, I have a feeling that's probably what did me in, at an earlier age. And she said, women that have major stress, like they've had an illness, or they've been hospitalized, or they've gone through a bad divorce, or they have some, they lost their job, those kinds of things can certainly accelerate that. So I think getting back to what you're saying about the people who are super stressed out, whether it's circumstantial, beyond their control, et cetera, that can definitely push you over. Now, I want to make sure that we at least can touch on some of the changes women can expect. I think women are sometimes surprised to know that, like, muscle mass, as an example, is something that, we start to lose. I think it's 0.7% of muscle mass each year in our 30s and 40s. And that this actually, muscle is this organ of longevity. It impacts our insulin sensitivity. It can be improved with estrogen, estrogen replacement, obviously bioidentical. But the concept of sarcopenia, I think for a lot of people, they've never heard that term. They don't know what that means. It's muscle loss with aging. It's not a question of if, but when, but it's certainly something for myself that keeps me very vested in making sure I'm having that conversation. And I'm sure as a GYN, you probably have women in your practice that were menopausal, but we're kind of like skinny, super skinny, but they lost all this muscle mass. So they just look skinny. They don't look like they have defined muscles. And I remind people, like, that's not a look you want, because usually what goes along with that is osteoporosis and sarcopenia. And maybe this is someone who, back from the WHI study, is now concerned / fearful of hormone replacement therapy, but understanding that, our muscle mass can improve with hormone replacement therapy.
Yeah, I really feel for women who are, 50 and over in this country, because they lived through the low fat, no fat era, and the high intense cardio aerobic jazzercise era. And all of those things were really harmful to women. We were trying to tell women, like, you can't eat any fat. You have to exercise until you can't even stand up, like you have to sweat, 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 and deprive, deprive, deprive. And what we learned is that shuts down your sex hormones faster than anything else does. And so what I'm seeing every day in my practice is those women still trying to recover from that brainwash, of cardiology and everybody else in the medical field saying, don't eat fat, exercise more, eat less. And so they're having a lot of mental blockages trying to make this transition. And when I explain to them, like, you need to do intermittent fasting with a healthy ketogenic diet, they're scared to death, or you need to do weight training instead of 5 hours of jazzercise. They're like, I'm going to bulk up and be fat. And what are you trying to do to me? And it's just trying to get rid of all of these lies and all of these myths that we told them for so long as medical professionals who didn't understand health and wellness whatsoever, and so finally cardiology and all these societies are putting their tail between their legs and saying we got it wrong, but they're doing it in a very quiet way. Media is not helping whatsoever, and so women are confused. And I'm really glad that you wrote this book, because it's important for women to understand that your sex hormones, your testosterone and your estrogen, your progesterone, they come from a cholesterol backbone. If you aren't eating healthy fats, you will go into menopause. You will stop making those hormones. And what we see is as soon as you go into menopause, your cholesterol goes up. Well, no, duh, you're not using it to make those hormones anymore. And everybody panics and says you're going to die from heart disease. It's not, because your cholesterol went up. So I really, we told women take all this calcium when they're in menopause. And then we found out that calcium goes and helps block your arteries. Like, we've done a lot of things wrong as a medical institution in this country, and as physicians and nurse practitioners. And we just need to say, we made a mistake and we were actually wrong, and it's okay. And this is, what the science is panning out to show, is that the way God created us with this innate intelligence and this ability to not eat for days and then eat and have a feast and not eat, like, that is literally how we're supposed to function. So we just need to get back to how our bodies were made and honor that innate intelligence and our physiology and our homeostasis, and stop trying to muck it up, with these fads and everything else.
No, I couldn't agree more with you. And I think on a lot of levels that I cringe, because, in the early 2000s, we were still perpetuating seed oils and eating lots of complex carbs. And so it makes me cringe, but I'm glad that slowly, the knowledge is getting out there that healthy fats are important, high quality fats are important, adequate amounts of protein, that fasting will not hurt you. Couple more things I just want to touch on, largely because these are things that clinically I wasn't dealing with when I was working in cardiology. Number one, vasomotor symptoms. For the people that are listening, they're like, what does that mean? Unless you've experienced it, you cannot, it's like almost as if you're burning from the inside out. And I recall exactly where I was the first mini hot flash, because they were never severe, but we know like 80% of women will experience them. And some of it's I think a lot of people like to blame estrogen, like, oh, it's because estrogen's falling. And yes, estrogen's involved in temperature regulation, but it's so much more than that. And it's interesting when you look at, like, you can break it down by demographics, you can break it down by race. 25% of women will experience minimal ones. And then there's like another 50% that are kind of in between. And then there are people called super flushers. Now, you never want to be one of those, but it's interesting when you look at the research, alcohol and caffeine appear to be two risk factors. I would add into that insulin resistance, because the worse your insulin resistance or diabetes is, the more likely you are to be in that 25% of super flushers. And thankfully I can count on like two hands how often I've had them, but they're never pleasant. They're never fun. What are your thoughts about that in terms of when you're working with a woman and she's dealing with out of control hot flashes, which are not fun?
I couldn't agree more. The women that come to me with those complaints are the ones that hate their job and they don't want to confront their boss and they're absolutely miserable, or they're going through a divorce, or they haven't spoken to their spouse in a week and they're on the verge of the divorce. Like, that is the kind of stuff that drives hot flashes. I promise you. Sometimes I also see, especially in younger women, hot flashes coming from gut dysbiosis, too much strep overgrowth in your gut. Or it can harbor up in your tonsils, like any of those things. Night sweats are a big one. So estrogen always gets the blame. And what I saw for 20 years is a woman would come in with hot flashes, and it was either me or a colleague would give them estrogen. They would gain weight and they would feel better temporarily, and then it would be bad again. And we'd be chasing this estrogen dosing. Oh, you don't need estrogen. Oh, you do. Oh, you don't. Oh, you do. That wasn't what was going on. Their blood sugar was dropping in the middle of the night to wake them up and make them sweaty because they were drinking 1 or 2 drinks of wine every night. They were, metabolizing all this sugar. They were eating snacks in the evening. We're still trying to recover from the ADA telling us to eat every 2 hours to maintain our blood sugar. Another lie. That's just not how our bodies were created. God did not put grocery stores on every corner of our world, for us to eat every 2 hours to maintain our blood sugar. So hot flashes, night sweats, mood swings, estrogen imbalance definitely affects this and worsens it, but it's not the primary driver. It's blood sugar, insulin, and cortisol almost every time. And then parasites and gut infections, the other times. So what I say to women is, don't drink alcohol for a couple weeks. Just see what happens. And if you can't do that for 2 weeks, that's a bigger problem, right? Mm-hmm. Like, you should be able to just not drink alcohol for a couple weeks to do a little experiment on yourself and see if you sleep better. Don't eat for at least 3 hours before you go to bed. You got to get that blood sugar stabilized, and it's not by eating more. It's by giving your body a rest from eating. That's key. I used to get a lot of complaints when I had my practice of women having to pee during the night. Oh, I got to get up and pee. I got to get up and pee. And they thought my bladder's failing, and so we'd put them on medications for urgency and overactive bladder, which are a nightmare in of themselves and have all kinds of problems. It's not your bladder. It's your blood sugar. It's your cortisol dysfunction. I promise you. So don't be quick to jump on those overactive bladder medications, because that constipates you, which irritates your bladder. That makes your gut dysbiosis worse. That medication makes you super thirsty because it dries out your body. And so then you end up drinking more, and that can make you want to pee. So I swear, all these medications that we give women to fix their problems just cause 5 new problems. It's super frustrating. It's not only frustrating for the patients, but for me as a provider, because they're like, why don't I feel better? And now why do I have this problem and this problem and this problem? So stop medicating everything.
Well, and it's interesting because, I never share these things in an effort to make healthcare professionals not sound professional at all.
Right.
However,
exactly.
it used to be a running joke that you would put someone on a blood pressure medicine like hydrochlorothiazide, which is a diuretic, which would then you would have an increased renal loss of potassium. So then you have to put him on a potassium sparing, either a potassium sparing agent or potassium replacement. And then the diuretic, this one in particular, would provoke gout. And so it was like literally the domino effect. You put them on one drug and they end up on 5 more. And so what Dr. Tabatha is really emphasizing is we need to do the work so that we don't have to be on all these medications, and understanding there's a root cause. Now, ironically enough, one thing I wanted to touch on before we end our conversation, and I could just talk to you for hours, so we'll have to have you back for another episode.
I know.
Vulvovaginal issues in menopause are a huge issue. And I would imagine most, if not all, women are very uncomfortable having these conversations. And so for anyone who's listening, 15% of women will develop these early on, but by the age of 60, it's almost 75% of women. So it's not a question of if, but when, and it's a direct reflection of the loss of estrogen in the vaginal microbiome, just like you were mentioning the gut microbiome, the mouth microbiome, the vaginal microbiome. Disruptions there have a profound impact. It changes the pH level of the vagina, which contributes to all these problems. Let's at least talk about this, because this is what I would consider to be probably the most taboo subject for women to talk about. Like, they may be able to talk about the hot flashes and the weight gain, but talking about their vaginas is something that they're deeply uncomfortable. And so I'm hoping we can have a discussion and get some good information out there so women can better advocate for themselves.
Oh my gosh, yes. And, if they're brave enough to ask about it, or if their gynecologist actually asks about it, they don't usually have the best solutions. I would say, in my bag of tricks as a gynecologist, I would give you vaginal estrogen, and tell you good luck. And that's kind of all I thought about or had for you. As a functional medicine provider, I'm thinking about the vaginal microbiome and the fact that your pH balance shifts so much once your estrogen level declines permanently. And so vaginal symptoms are one of the first ones to come on with chronically low estrogen. All of a sudden, things are dry and irritated, and it doesn't feel good. It's not just with intercourse. Intercourse can be very painful, but that tissue in the vagina, the skin actually thins out. You lose this glycogen mucus producing layer, that supports lactobacillus. And so it can almost be as thin as tissue paper. So imagine how easy tissue paper tears. That's what happens to the vagina with intercourse, or even just physical activity, because the vagina is a potential space. Like, it's a tunnel, with the cervix at the end of the tunnel connected to your uterus, but those walls are usually closed up against each other, right? So when you put something in, you separate those walls. If those walls are constantly touching each other, you can actually get agglutination. So that skin will grow together. And when you try to pry it open, it tears and it bleeds and it feels horrible, So I used to do exams on women all the time. That's all I did all day long. And if you're not having intercourse regularly, putting that speculum in is miserable, because I'm finally separating those walls that have not been separated and that have been deficient in estrogen for a long time. And so the same thing happens when you go to have intercourse for the first time in a long, long time. It's miserable. So you really do have to support the microbiome, the bacteria that live in the vagina. And that starts with having healthy microbiome in your gut, and probably being on systemic estrogen or some local vaginal estrogen, or you can use the precursors. You could use DHEA. That's another one. Some women will even do progesterone and testosterone vulvovaginally. So there's all kinds of benefits there. And you need to find a practitioner who prescribes these creams regularly, because they're not a standard prescription. They have to be made at a compounding pharmacy. You have to have a prescriber who understands how to dose that properly and, write for those prescriptions. But there is relief, and I always get the comment, well, if God wanted us to have all of that, he would have made menopause later. Well, the average age of women was 49 just 100 years ago. And so we didn't live half of our life in the menopausal state. So this is all new to us, and we need to figure out how to manage that and have a good quality of life. And we deserve to have amazing sex and, be intimate with our partners and enjoy this time of our life, because we're finally not, worried about getting pregnant anymore and all of these things. And we deserve that. And so you do need to find somebody who can help you navigate that, because you don't have to be miserable. The other piece of it I see is your bladder. So not having that estrogen at reproductive levels anymore gets rid of the mucosal barrier inside the bladder that protects it from bacteria getting in and causing issues. And so the bladder is more susceptible to infections once you're in menopause. And it's really common for women to get 2, 3, 4 bladder infections a year. Not only are they miserable, but then you're prescribed an antibiotic to kill that infection, which also kills all of the beneficial bacteria in your gut, which disrupts your, metabolism of the little bit of hormones that you do have and everything else. So it's just this snowball effect. So, when I get to that time where I need estrogen, I'm probably going to go on estrogen. Right now, I'll tell you, I'm on progesterone. But I see so many benefits to bioidentical estrogen in just preventing the disease processes that set in with low estrogen. So, you really should consider it, as long as you're doing it with a practitioner who knows what they're doing and who, is well versed in all of this. But there are solutions. The other piece of it is things can start to fall, right? You and I had this discussion in your private Facebook group. Our collagen not only starts to be depleted in our cheeks and, in our arms, and things start to jiggle and sag, the same thing happens in our pelvis, in our vagina. So we lose the volume in our vulva, in our labia, in our lips. We start to lose the collagen support that keeps our uterus up, and things fall, and that can interfere with intercourse. It can cause accidents, of urine or even feces. So there's all kinds of things that go on. And so back to the beginning of our discussion, it's really important for you to have a good women's health practitioner in your corner when you're done having babies and you're going into the second phase of your life, because you need them more than ever, actually.
I could not agree more. And I'm so very grateful that, you joined me for a second episode recording. Please let my listeners know how to connect with you, how to find your great podcast, how to reach out to you. Because the one thing I know is Dr. Tabatha is licensed in many states. So she may be licensed in your state.
Yes, I think I'm up to 29 or 30. I don't know. I lost count. But you can go to my website at drtabatha.com, DRTABATHA. It's all A's, no I's. And you can sign up to potentially work with me if you feel like you need a one-on-one practitioner who can prescribe for you. If you just need support in other ways, or you want more information, you can listen or watch the Gutsy Gynecologist show on YouTube and podcasts, wherever they're at. And then follow me on Instagram and TikTok and all those cool places at the Gutsy Gynecologist. You just need to keep gathering more information and figure out what works for you, because we're all individuals, right? But I would say the big overlying arch theme is you can't balance your hormones with just hormones, right? That's number one. The gut affects so much of your hormones. You need to get back to eating the way God created you to be, with some fasting, super important. And then the piece that we need to come on again, right? We need to have another episode, because we didn't even talk about how women don't love themselves, and that whole mindset piece, and how we self-sabotage. And we have all these old recordings playing of all the lies that have been told to us. We need to break all of that cycle. That's a whole nother episode, but start there, do the work. We're here for you, and let us know what else you want us to talk about, because Cynthia and I could talk all day.
No, in all seriousness, for anyone who's listening to the second episode with Tabatha, I covered maybe 25% of what I have on my notes. So we'll definitely have to have you back. Thank you again.
My pleasure.
Hey, if you like this video, you guys are going to love this video, and I'll see you there.
We make almost all of our fat cells during childhood and puberty. And then once we finish puberty, we're done. That number of fat cells, in most people, there are some people who are an exception to this, and that's about 15% of people who are in the obese category. But most people reach a limit, and that's their fat cell number essentially for adulthood.